So coronavirus, I'm going to talk a bit about what it is, how we've used our past experiences with other coronaviruses to shape what we're doing now. Hopefully allay some fears, because that's the most important thing at the moment. People are understandably very scared because we have a new disease that we haven't seen before, although we have seen similar before. But people are frightened, very frightened about it, and I really get that, and it's really important that you're not, because if you are not completely confident and you are worried, then you may not be concentrating, or your mind may not be completely on your job, and that's when mistakes can happen and slips can happen. And and here in the Trust, we really want people to be as safe as possible, and it's in our interest and in your interest for this to happen, because we are going to need you to look after the people that are going to be coming our way, and we need you to be safe as well. What I really want you to do is watch out for fake news. There's a lot of it around. Facebook, I'm afraid, is a nightmare, okay, for it. So a couple of days ago, somebody was saying, oh, well, there's 3 doctors on intensive care unit at St George's, So Mike Aisbit, the A&E consultant, rang up his friend who runs that unit, and there are no doctors in intensive care unit at St George's. So there's a lot of fake stuff. If you want to follow or get some good up-to-date information, Twitter actually is the place to go. And if you follow people like at SM Hopkins, who's the infection control lead at Public Health England and also an infectious disease physician at the Royal Free, you'll get really good information. If you follow me and have a look at who I follow, then you'll see people publishing, putting on quite new scientific information as it becomes available. And new stuff comes along all the time. And I've changed this talk overnight, for example, with a couple of extra little bits. Okay. So there are a number of respiratory viruses, and you'll see that coronavirus is already on this one because it causes the common cold. Okay, there are 7 different types of coronaviruses, 4 of which regularly circulate anyway, but there are a number of other different viruses. Influenza viruses, parainfluenza viruses, RSV, that sort of stuff. And so the respiratory viruses are not unfamiliar to us. It's just this is a new one that we haven't seen before. But we have seen something similar. And the problem with this is, why has it become so bad, is because at the moment there's no immunity to block transmission. So with influenza, every year Public Health England will look at what the flu strains that are likely to be circulating, and they continually circulate, and they will go for maybe a trivalent, maybe a quadrivalent vaccine, which maybe has 3 or 4 different flus in it, and that reduces the susceptibility of the population. So you give it to the high-risk people, the elderly people, and then you reduce the population of people who could get infection. But we have not got that, and I can't see a vaccine for months at the moment. Okay, so we have a population we assume are completely susceptible to this, and we have no vaccine. So therefore, the mathematical modelers have predicted where the disease curve could go, because it does seem to transmit fairly rapidly from one person to another. And I'll talk about how transmission happens and how transmissible this is in a while. But there's a lot we're discovering, and science is really rushing ahead. I mean, huge advances have been made in weeks that would have taken years a while ago. So we're finding out the incubation period is very much like MERS now, and we're finding that actually quite a few people have had it asymptomatically. So they sampled quite a large percentage of the population in Iceland, for example, and half of those who tested positive had no symptoms whatsoever. And there is a suspicion that we may have had it here in the UK. I think we have, to be honest, because if it started in China in October, November, the first flights coming from China were not in October, November. And if you talk to people, they'll say, do you know, I know someone who had this terrible cough and they felt like death for a few days, and they were in bed for a few days back in November, December. And some other mathematical modelers at Oxford did some modelling on that, and they suspect that possibly half of us may have had it already. But we don't know that at the moment, because the only test we're doing is a test to see if you have infection. So that's where the accent has gone on to antibody testing. Okay, so the government announced 3.5 million antibody tests yesterday. Boris said they'd be available within days. It's not going to be days, of course, but it is going to be soon. So Public Health England are validating them at the moment to make sure they are kosher. They do what they said they do. So are they sensitive? Are they specific? And if they are good, then we can use them for healthcare workers, and they're going to make them available to the public to buy if there's enough left. Okay, so that's important. So at the moment, we don't know whether the asymptomatic carriers will transmit but it's possible that if you're not symptomatic, so you're not coughing, you'll definitely transmit less. Okay? And knowing how the disease transmits is really important if we're going to try and reduce the spread. So these are called coronaviruses because they've actually got a crown or halo around them, so it's done on the physical look of them. They're envelope viruses, so viruses are either enveloped or non-enveloped, and non-enveloped viruses are things like norovirus, the tummy bug type ones. And envelope means that's very good news because it means it's easier to kill, so that's helpful. These coronaviruses generally affect the upper respiratory tract, and they have a big impact on society because, lots of people get colds during the winter and they're off for a couple of days, and if you're a man, you're off for a month. But they have a significant impact on society, but they continually circulate. That's the human ones. Okay, and you could potentially get secondary bacterial pneumonia, as you can with the influenza. But some of the new ones are zoonotic in nature, which means they've come from the animal chain and got into humans through mutations. And that's the ones we haven't had any experience of, which means we're completely susceptible to them. So there's 4 endemic human ones that continually circulate around the world. But the human zoonotic ones that started in 2002, the first one was SARS. Anybody remember SARS? Yeah. And then we had MERS in 2012. And now we've got this new coronavirus. And the virus is called SARS-CoV-2. Okay, because it's very similar to SARS. And the infection, we're calling the disease COVID-19. So they're both the same thing. So the organism causes the infection. And COVID-19 stands for coronavirus infectious disease 19. Okay, all of these came from bats. Okay, yeah. So the first one, SARS-CoV, came from bats and went to palm civets, which are like cuddly little cat things, and you can see in Chinese markets, mixed up with other mammals, got into the human chain. MERS went from bats to camels and then into the human chain. And this one seems to be bats, well, it is bats again, but it's gone through pangolins in this case to get into the human chain. And so bats are the reservoir of these coronaviruses that have the potential to get into us. But, flu viruses come from birds out in Asia, and they constantly change and circulate. So when you don't know what the illness is or the disease is, you can go on previous experience. So as soon as you find out it's a coronavirus that's probably zoonotic in nature, you then think, okay, what happened before? So reflect on what happened before. And SARS, 2002, global health alert by March 2003, from one hotel in Hong Kong, it went to 24 countries. Canada had a horrendous problem with it. Actually, a lot of healthcare workers, because they were not dealing with their PPE correctly. And their bad experience, has taught us a lot about how we use the PPE correctly when we're challenged with it. So you don't get the same sort of situation as that. Clinical picture, severe pneumonia, 8,000 infections, 1 in 10 mortality. Okay, very high mortality, mostly over 50 and male. So as I mentioned, it's come from bats and got into animals. But by 2003, it disappeared. So this did not spread rapidly from person to person. Okay, it was people with very close contact to an infected case, but it didn't really seem to contaminate the environment too much, although it did in healthcare. But it just disappeared, and we've never seen it since. MERS is slightly different, so that appeared in 2012, and suddenly they had this huge number of cases in Saudi Arabia, 1,000 cases, death rate huge, initially high, 30 to 40% of people died. Yeah. Big parallels with SARS infections in the way that it seemed to spread. Again, zoonotic, tomb bats in Egypt, camels, and in fact, when they tested the camels, 90% of the camels in Saudi Arabia had this. 2,500 cases, 35% death rate. So that's where people were really, really worried about this at the beginning, because if it transmitted very quickly and had a very high death rate, then we're really in big trouble. Okay. Actually, MERS never went away. You still get the odd case in Saudi Arabia, as the camel still had it. Most of the camel farmers have antibodies to it, so some of them had subclinical infections with it as well. They did do a camel vaccination program, but actually the Saudi Arabians imported a load of camels from Australia, which has the biggest wild camel population in the world, and there's no tomb bats out there, so they were all coronavirus free. And so that brought the reproductive factor, which we call R0, down to less than 1. And the reproductive factor is something you calculate when you've got an infectious disease. In other words, if I have it, how many people will I give it to? And that's really useful. So if it's 1, I'll give it to one person, and that person gives it to one person. It means it's not going to cause an epidemic. It will kick around, but it's not causing an epidemic. If it's less than 1, it's going to die out. Okay, so if it's 0.68, for example, if 100 people have it, they will give it to 68 people. And those 68 people give it to something like 42. And those 42 give it to 30, and it just declines. This at the moment has an R0 of about 2.5 to 3, which means if I have it and you're not, you're susceptible, which we think everybody is, but we don't know, then I give it to 3. And those 3 people give it to 9. And those 9 give it to 27. So you can see it goes like that. Yeah. So what you have to do is work out, okay, how can we interrupt this, which is why we're all in lockdown. So what you can then do is chart them out. So here's SARS, here's MERS and SARS-CoV-2 on the right, and you can see all the similarities apart from the number of countries. 27 countries for MERS, 29 countries for SARS, 167 countries it is now for COVID-2, and that's because it was already spread well around the world before they actually put in the control measures. All bats, look at the numbers of cases though, 8,000, 2,500, 417,000. Incubation period is pretty much the same. At the beginning we're going with the MERS, which is the worst case, 2 to 14. Now we think it's more likely to be 2 to 7, the incubation period. Occasionally you get someone who's possibly 14 days, but they may have had another exposure in the meantime that you don't really know about. Infectivity started at 2.2 for SARS but dropped to 0.3, so that went away. MERS has dropped down to less than 1. At the moment we're 2.5 to 3. And there are some people who seem to contaminate the environment a little bit more. I take that with a little bit of a pinch of salt because it does depend on how well you decontaminate the environment around them. But that means then the treatment is the same, it's all supportive, there's no actual treatment as such, and the infection prevention for the same. And we know what worked for the others, therefore we know what will work for this. So it's droplet protection and contact precautions and face shields that are going to work for us. Now everybody gets very concerned about mortality rates, and I absolutely understand why. And you'll see in the papers, why is Germany 0.3% and we are 4.9% and Italy 9.2%? And that depends on a number of factors. So at the beginning in China, for example, it was 17%. But they were hardly testing anybody. They were only testing the people who came to the hospital who had severe respiratory disease. Okay, so if you only test those, then you get a high death rate because some of those are going to die. By the end, when they're doing all the testing of the people who are positive, the death rate is 0.7. So it will likely end up around that, I think. But at the moment, we're not testing that many. We're testing the people who come to hospital who are symptomatic. People who are self-isolating in their home, not testing. The antibody test is really going to help us work out how transmissible this is. So it's nothing like as transmissible as we feared, it seems, possibly. So the things that affect this rate is the number of cases detected by testing, varies by country, and I'll show you that in a moment. Selection bias means you only test the more severe, so that doesn't help. Sometimes, there is a delay between symptom onset. So if you test me now, I go into the figures as a case, but I don't die for 2 to 3 weeks, then there is a bit of a lag. So that will affect the figures, maybe more at the beginning, but not so much now because we've got so much data. Other infections, sometimes people will die of another infection. If we put people on a ventilator, we've got to make sure they don't get a ventilator-associated pneumonia. If they have poorer healthcare systems, what about the population demographics? Italy has the oldest population in Europe, although Germany has the second oldest population in Europe. And it's interesting to look at what's happening there. Sometimes people die with coronavirus, and maybe they had a malignancy, and that's actually what they died of, but they died testing positive for coronavirus, so it goes on the death certificate. So there's a lot of things that are involved in the death rate, and eventually we will get to what the true figure is, but at the moment that's all we have. If you look at what's going to happen going forward, the ICU provision, Germany has 29 ITU beds per 100,000 population. Italy has 12.5 and we have 6.6. So we have a quarter of the number that Germany has and half as much as Italy. That's not going to help. And also the age of those infected. And in Germany at the moment, the median age is 46. So that's a younger population, so the death rate is lower. In Italy, it's 63. Here it's 64. So it's the older people are more likely to get, to actually to succumb to this. So that also will skew things, and it may well be that in Germany it will move up up into the age groups. But also think about cultural aspects of this. So in Italy, The grandparents are very much part of the family. And everybody comes together for the family meal, and there's lots of hugging and kissing. My kids see their grandparents not once a month sometimes, once every 6 months. And when they do, it's all right, Nana. It's not arms around them as much. So there are cultural differences that maybe help or have helped transmission. And there's it's going to be some good information coming out of this. Just show you testing. Korea's been ahead of everybody. They test 550 people per 100,000. Australia have tested huge numbers of people. In the UK, we're doing about 100 per 100,000. America, 17 per 100,000 population. They just haven't been testing. Because it's going to go away in days, according to Donald. And they're all going to be working again by Easter. Yeah. So, symptoms. Okay, incubation period, you think probably 2 to 7 days, peaking about 5 to 7. Similar to seasonal flu, that's the same sort of incubation period. Most people have fever and dry cough. Okay, and that comes on quite rapidly. Suddenly, oh God, I'm feeling terrible. Symptoms last about 5 to 6 days, at which point you'll either recover or develop more severe illness. That starts about day 7, which is shortness of breath, lung inflammation, pneumonia, and that's when they're more likely to come to the hospital. Okay. So 88% of people get fever, so that's not 100%, so some people don't get a temperature. Yeah. Dry cough, 68%. Then you've got the usual viral things like fatigue, muscle joint pain, sore throat, headache. Shortness of breath, though, you don't get with flu so much. Sputum, I'm wondering about because it could be a bit of a red herring because people have got respiratory problems will be producing sputum anyway. So there are differences in the symptoms. So if you look at this, there's a nice microbiologist in New Zealand who actually is an artist as well, and she drew this. So you've got COVID here, flu and cold. So dry cough, COVID and flu, but not so much a cold. Fever, COVID and flu, not so much a cold. Runny nose, no, useful, but runny nose a lot with a cold. So if people have got a terrible sniff, you see them blowing in their nose all the time, then they've got a cold. Yeah, sore throat, not so much as a cold, but breathlessness is significant. Yeah, and then headache and body aches, etc., etc. Notice the top right. Diarrhea, no. So we did not need to empty Tesco's of toilet roll. And in fact, we should use Tesco's as our indicator of communicable diseases in future. So if all the toilet rolls are gone, there's an upper respiratory problem. And if all the nasal spray is gone, then it's diarrhea that's circulating in the community because people seem to have got it completely, well, they don't know their from their, yeah. Anyway, yeah. So severity of illness. Now, this is a bit tricky because we don't know about what we don't know, and the antibody test, when that starts, will tell us about the undetected, because we found that a lot of people have no obvious symptoms. They're talking about Prince Charles. He's at home, self-isolating. He's actually classed in the papers as working from home. So he's all right. And most people are like that. 81% of people, the cure is time, or going to bed for a few days if it's a bit more severe. But 14% get a big drop in their oxygen saturation, they're breathless, they need oxygen. They're going to come to hospital. And 5% will need ITU. So 5% of the whole population who suddenly got it very quickly means our health system collapses. So that's why we're doing what we're doing, okay? Because children do get it, but they get mild disease in general, and that's a generalisation because there's always a spectrum of every disease. Some kids will get it and get no symptoms whatsoever, and some will get it a little bit more severely. Okay, it's more severe disease in older people, especially if they are diabetic, have heart disease, chronic respiratory disease, and many old people have all of these. And that's what happens as you get old. All your systems start not to work very well, and you get susceptible to something that's going to take you out effectively. Immunocompromised. People have been very cautious with the immunocompromised, but I've read a very good paper this morning that says that illness in the immunocompromised is no more severe than it is in the other population. So that's a little bit reassuring. We'll still be careful with it, but that's an indication that if you are immunocompromised and on chemotherapy drugs, then you aren't going to suffer as badly as we feared, so that's helpful. Overall, we probably think less than 2% of cases will be fatal at most because of the lack of obvious symptoms. We don't know that number yet, and we won't know that number yet for a year or two until we get the antibody test. That's why we get a very low death rate from flu. It's because they do antibody testing at the end of the year, looked at who had flu, look at all the people positive in the population, you get a low death rate. But we're nowhere near that yet, and that's of interest later, possibly. So calculating contagions, as I said, you use the R0. So if it's less than 1, it'll go away. If it's 1, it'll just tick along. So we need to get it to less than 1. But if it's more than 1, it will just keep going until one of 3 things happens, or all of them. In other words, most have had it, and to really stop transmission, 80% of us need to have had it. Or there's a vaccination, which means it stops it, or we put in control measures. And at the moment, we don't know about that. Now, 50% of us have already had it, which is a hugely optimistic view. If we have, then that's really going to help. Vaccination is months away. So what we're now doing is effective control measures, which in the hospital, when we're dealing with people, that's use of our PPE. But outside hospital, that's the social distancing, okay, which people were not doing particularly well, and potentially still aren't, I don't think. So transmission, this is, it actually doesn't compare from the pathogenicity aspect with SARS and MERS because they had much higher fatality rates. But this seems to spread much more. Well, it does spread much more rapidly. They didn't spread hugely in the community. These have. But so even though the death rate is much lower, it's still, because of the number of people affected, hugely significant for us. Okay. At the moment, as I say, the R0 is about 2.5 to 3 people. So what we need to do is stop the spread. This is that microbiologist in New Zealand again, and the green, when you see the green one come up, that's us doing nothing. And the line across there is healthcare system capacity. So if we all do nothing, apart from stock roll toilet paper, we collapse quickly. If we do what we're doing now, strong collective response, then it goes up and then it starts to decline. And at that point, you hope maybe vaccines got in, or you can work out that a lot of people have had it. The worry is if we aren't getting this collective immunity, then we stop doing everything and it goes down and everybody then thinks, oh, it's fine. And then off we go again and the healthcare system then collapses at the end of it. So, we're still in the finding out phase, but the antibody test, I think, is going to be so useful for us going forward and probably will change what we're going to do. So when Boris said it'll all be over in 12 weeks, I don't think he actually did say that. It was interpreted as that. I think he's saying within that period, we will know where we're going. Okay. So to work out the R0, you look at things like how it's actually transmitting. And the good news is, and I probably should have pointed out on that other chart, that if this is coughing, not sneezing. Sneezing is a cold. This is coughing. So coughing means it doesn't go very far. If you sneeze, aerosols go everywhere and you get little infectious particles. But a cough, really, most of it is big lumps that drop within a couple of feet. Sorry, old money. But small infectious droplets, 3 to 5 feet, so 2 meters. A sneeze would go into the air and kick around. Now, if something's spread by sneezing, it has a high reproductive factor because it kicks around in the air and then people can pick it up. So at the moment, it's 2.5 to 3, similar to the pandemic flu, which is 2.8. So that tells us it's droplet. Okay. Things that are more airborne, like chickenpox, you take your kids around to see other kids. Infectivities, 4 to 5 children will get it from an infected person if they're not vaccinated. Compare that with measles, which really is airborne, 12 to 18. So if it was 12 to 18, we would all be wearing respirator masks, but it's not. So that tells us what we need to do. So it's respiratory droplets and direct-indirect contact with infected secretions, and that is generally within a couple of meters. Now, if you're unlucky enough to be 2 meters from somebody, within 2 meters of somebody, when they cough, you might get some onto your own mucous membranes, which is why you wear some protection, okay? But you're not going to inhale it, it's just going to land on the surface of the mask, okay? But of course, if there's no one within 2 meters, what I'm coughing out contaminates the surfaces around me. And people touch those and then they self-inoculate themselves. So that's the other thing. So that surfaces are a potential reservoir and have been in all of the outbreaks over the years, but if they're not destroyed. So that can be done through chemical methods, through disinfectants and soaps, or can be done through physical methods, like if it dries. So they do not survive very well on porous surfaces because the moisture gets absorbed, that leaves the virus pretty much exposed and it does not like it. So when somebody coughs, you don't cough out little viruses, you actually cough out lumps with the virus in it. Yeah. UV light, though, is very good at destroying these viruses. Sunlight is fantastic. A couple of hours of sunlight is very effective against these viruses. And the maximum transmission risk is from people is when they first become viremic, when they're first getting symptoms. That's the same with any viral illness. When you're first showing symptoms, that's when you're the most risk, because you have huge amounts of replicating virus and you're much more likely to transmit it. Okay. To show how much these respiratory viruses are around, we come into contact with them all the time. If you travel on public transport, you've got an increased risk of about 6 times, unless you do it a lot, in which case you have less risk because you've been exposed more often, so you get immune. We talk about air travel, okay, and it's quite interesting, air travel, because it's not just the person on the plane who flies from A to B, it's also where the plane goes. So I was in the Gambia back in February, and because I'm a geek, I look on flight radar, which tells you where your plane is, but you can also see where the plane's been. So although I was flying from the Gambia back to Manchester, that plane had been to Italy 3 times, to Austria, to Switzerland, to Greece a couple of times, and then to other countries in that time, because they're just little buses that shuttle all over the place, and they don't just go from A to B, they go X, Y, Z, etc., etc. And as you know, a modern low-cost airline has fantastic cleaning procedures between everybody that involves opening the back door and the front door and getting everybody off, and maybe picking up the newspapers. Now, most surfaces on a plane are actually porous, like the seats and that sort of thing, so probably less of a problem. You don't touch those. But the thing you do touch is the tray in front of you put your food on, which is a hard plastic, and that's what these viruses survive best on. You're talking days. So I have to say, I tend to wipe the tray when I go on the plane. Now, actually, somebody did some work in an airport just to see what surfaces are contaminated there, because so many people travel around the world through the airport, and the most contaminated thing is the baggage screening tray, because everybody touches it and it's made of hard plastic and it is never cleaned. So just think about that when you go to the airport, because you get your stuff screened and you think, thank God it didn't go down the other side where I'm going to find one lip salve after about an hour. So you're so relieved, you go off to get a coffee and a muffin. Do you clean your hands before you do that? And you've touched everything. Maybe think about it. Anyway, so how do these viruses actually get to us? Well, they survive very nicely in the environment if you haven't been actually coughed on, but a mode of acquisition is not inhalation, it's intranasal inoculation, which we do a lot because we do this all the time. And this was a study where they told some medical students, we are going to be watching your hand contact during this lecture, and even then they still did this 23 times an hour, because you can't help it. Because people do this, and it's just human nature. It's what we do. Some people do it a lot. What we have to be very careful about is we're not doing it while we're working in healthcare. Okay, it's not a great habit to be in anyway. But you know, if you're wearing PPE, you really do not need to be touching your mouth or eyes or anything like that, because the environment does become contaminated. Now, this is a MERS outbreak in Korea. Korea does not have an enormous camel population, especially in the hospitals. But what happened was a chap from Saudi Arabia who was not well flew to Korea, and when he got there he felt really terrible, so he went to the hospital, and after 5 hours he got bored, so he went to another hospital. He sat in A&E, nobody did anything with him, so he caused outbreaks in both hospitals. Now, it's not his fault. I would say the cleaning procedures and the infection control procedures in these 2 hospitals were not good, but they were big outbreaks in both hospitals. Because he was coughing up, and actually, but afterwards, of course, they do some studies, and they looked at patients with MERS. And don't forget, you up the cleaning supposedly if you've got somebody with a respiratory virus or there's an infection, and they still found viable virus on about 1/5 of all surface swabs. So that's things like stethoscopes, because they're self-cleaning, aren't they? Ambu bags, call buttons, keyboards. You see, people work with the gloves and then they take the glove off. They don't think, I don't need to clean my hands. Well, and then they go to the keyboard. But that's there for the next person. That floor I'm not too worried about, to be honest, because shoes aren't, you don't come into contact with them very much. So people just weren't doing any cleaning. And cleaning just works. It's so easy. Because these things are envelope viruses. And an envelope virus means it's got an oily, waxy layer around it called a lipid layer. So you just break that apart and that's it. Game over for the virus. So really easy. This is, to kill. And some soaps will do it actually if there's a reasonable amount of surfactant in them, but most disinfectants are absolutely fine against this. And the wipes we use here are fine. 1,000 parts per million chlorine is fine, but fixtures and fittings, things we touch, are a significant risk. And I know there was a story last couple of weeks ago going about, it's petrol pumps. Well, they're out of doors and probably getting UV light a reasonable amount of time. But what you do touch is, because who spends less than 30 quid on fuel, is the keypad when you're doing the, I can't use contactless. Everybody's using it. So I know they've upped it now, haven't they, I think? So that was a good thing to do. So surfaces become contaminated because of directly from coughing and sneezing. But then what happens is the staff are working in their area, close contact, that's all fine. Oh yeah, I need something from over here. So you go over there and you touch something there and you've contaminated it. And the next person then thinks, I'm not 2 meters away, I don't need to wear gloves, and they contaminate themselves. So think about what you're touching, Contamination is greatest if you're having to do an aerosol-generating procedure, and I'll tell you what that is in a minute, because there's chance of it aerosolizing, so therefore a little bit more spread. But in significant numbers on surfaces, we think less than 3 days probably. It depends on the surface. As I said, plastics, so they'll survive longer on, and then metals, and then porous surfaces not particularly long. You will see the odd study that says we detected it after 10 days, but that's done in the laboratory under completely controlled conditions of not particularly high humidity, and high humidity does not do these viruses any good either. But the good news is they're easily removed by cleaning. As I say, chlorine's fine, and the wipes that we use are absolutely fine as well. What we do with the waste and laundry is exactly what we do for any other infected patient. So orange bags for the waste. Laundry goes as infected laundry, because then it's not handled when it gets to the laundry. Body fluid spills, as the usual policy. Uniforms, what we should be doing anyway, because you will be working with people with infection that we don't even know about. Not COVID, but other infections. Just try and wash your uniform separately if possible. Don't overfill the machine. I know we'd like you to wash over 60, but probably 40 with the dilution factor, and the soap is going to be okay. If you hang them out to dry, the UV would kill everything anyway, and ironing will definitely sort out anything on your uniform. So I'm not worried about that. If you've got somebody in the house with flu, you don't wash their clothing separately, do you? So it's exactly the same sort of principle. The dilution and the water changes would sort that out. Please don't forget about patient hand hygiene is very important, because they don't do it very well. They're even worse than the orthopedic surgeons. So after coughing and sneezing, before eating and after the toilet, if they've got a hand wipe there, you have to prompt them. I'm actually doing some research on this with colleagues at the University of West London. You can put things in front of patients, they do not use them. Yeah. So all the hand wipes go back to the kitchen, which is a huge waste. Just say, would you like to clean your hands, and open the wipe for them, or give them the alcohol gel and ask them if they would like to use it. You may have noticed that precautions changed. So at the beginning, we were thinking, if this is really airborne, till we know, we're going to use these. And that's because when we don't know, we go with ISLAGIAT, which stands for it seemed like a good idea at the time, but now we know more. So we know it's droplet, so therefore the precautions are exactly what we do for flu. And we know what we're doing for flu. We've done it before, so it's exactly the same. Okay? The bug's not flu, but it is a respiratory virus that behaves in exactly the same way as flu. So when people say it's just flu, it's not just flu, but what we do is the same for flu. So therefore, surgical masks are absolutely fine for the vast majority of procedures, because they will effectively pick out large respiratory droplets, and for that, they are as effective as these respirator masks. Okay? And there is good scientific studies, and there was a review published by Oxford just this morning that looked at all of the evidence and found no evidence that these are any better at large droplets. Okay? It's only the small particles from an aerosol-generating procedure. So we still need to use those for that, and we need to protect the stuff, and it's not about us saying we haven't got enough of these, we mustn't use them. It's a waste. And I was on a call with a colleague in Slovenia yesterday evening who they don't have enough of these. So I put her in touch with another chum of mine in Nebraska where they are reusing these. And he's written a procedure to do it with ultraviolet light, and that's the best they can do. And we're not at that stage. Okay? But that's what they're having to do. So, summary precautions then for PPE. If you have close patient contact within 2 meters, nursing staff this is, apron, surgical mask and gloves. No need for a long sleeve disposable gown, no need for the respirator. Think about the need for eye protection if the patient's coughing a lot. Okay? If you just go into a room but no contact with the patient and the environment, it's a surgical mask. And that is not to stop you inhaling something, it's to stop you doing that. Okay? That's what that's for. If you're just cleaning the room there, like hotel services, apron, surgical mask and gloves. For aerosol-generating procedures, it's the long-sleeve gown, the FFP3, respirator, eye protection and gloves. So just remind us about standard precautions, because other infections will still go around and we need to protect ourselves and others. You wear gloves if you've got direct contact with blood and body fluids, so you risk assess the procedure. People think gloves are the cure-all for everything, and we do hugely overuse them. So if you need gloves, you put them on immediately before that particular procedure, and then you take them off and you decontaminate your hands. If you just put a pair of gloves on and keep doing lots of tasks, all you're going to do is move stuff around, because people, when they've got gloves on, never decontaminate their hands. And gloves do pick up things and they do deposit them. So you'll be transferring stuff around. The alcohol hand rub is fantastic at killing these viruses and virtually everything else, apart from things like C. diff and norovirus. The aprons, again, when you think about how am I contacting things, am I likely to become contaminated, let's put the apron on. So standing in the room talking to somebody, you don't need to put an apron on. You're not going to come into contact with anything. Okay, so risk assess the procedure. If indicated, put on immediately before the procedure, take it off afterwards or when you're leaving the patient, and decontaminate hands. For patients with COVID, we're doing respiratory precautions, because the droplets are the transmission record. Therefore, patients will be in a single room or in a bay with other patients, and we wear protective clothing for close contact, 2 meters. Okay? Protective clothing for direct contact with body fluid, but we should be doing that anyway. Clean surfaces daily. In fact, we should up the cleaning frequency of the frequently touched surfaces. And if, have a look around your ward or department and think, what are people touching a lot? And often you see things like light switches as a frequently touched surface. Really, it's not, because it's once or twice a day. Then you're not constantly touching that. But there are pieces of kit that I may not know about, and you maybe haven't thought about, that people do touch a lot, and they need to be cleaned a lot more regularly. And that's with the detergent, followed by a disinfectant or a combination product. And then for patients, we will use, in these areas, we'll use dedicated equipment. Okay. In some areas of the hospital, we'll be doing more aerosol-generating procedures. We're talking about ICU. In which case, because they're dealing with suction and intubation, therefore staff will wear FFP3 masks with or without eye protection all the time. If they're with the patient, they don't need it if they're just walking up and down the corridor, but when they're with the patient, waterproof long sleeve gowns and gloves, which have to be changed, and people have to remember this. If you're working with somebody's catheter and then you go and deal with their vent, you don't want to transfer the bugs from their catheter to their vent, because then you give them a different infection. So that's not good either. These FFP3 masks are good for the aerosol generating procedures, and I think the list is up next. They filter out very small particles, and they'll protect you from inhalation of very fine airborne particles, which is if there was sneezing, then you would have to be wearing these, but you don't get sneezing with this. Okay. The filtration, however, is only effective if it seals to the contour of the face. It's really important. So therefore, you have to be fit tested for these. Okay. But if you're doing an aerosol generating procedure, you need to wear it. For other close contact, you don't. And these are aerosol generating procedures: intubation, extubation, related procedures, tracheostomy, manual ventilation, open suctioning, bronchoscopy. Now, we are actually also considering gastroscopy as an aerosol generating procedure, because I know if you put a scope down my throat, I'm going to cough. Okay, so I would class that as an aerosol generating procedure as well. Non-invasive ventilation, either BiPAP or CPAP. Surgery and post-mortem procedures if you're using high-speed devices, drills, that sort of thing. High-frequency oscillating ventilation, high-flow nasal oxygen, induced sputum, some dental procedures if there's drilling going on. And we're also thinking, if you've got patients who are coughing a lot and you're turning them and you're in very close contact, it's possibly worth wearing that at that point, because they'll get a big cough. For a known or suspected person, just routine contact, surgical mask is fine. Close contact, 2 meters. Blue side out. If you see people wearing the white side out, they got it around the wrong way. Very important, okay? Because that's the blue side is the water repellent layer. Eye protection for risk of splash, gloves for close contact, etc. Changing between procedures, apron for close contact. You only need the fluid disposable gown for aerosol generating procedures. General advice for PPE is take your time, because what you're doing will take longer. Keep your hands away from your face, very important. Change the gloves if they get torn or contaminated. Limit the surfaces you touch. Try and think carefully about what you're doing and plan what you're doing, rather than doing what you're normally doing. Just go and do that, but then think, oh, I need to do that, and oh, I need to do that. So, take your time and think, this is what I'm going to do on this visit. And then clean your hands after the gloves come off, but I'll come through doffing. I'll go through doffing in a minute. Before you put it all on, remember, keep yourself hydrated, because if you're going to be wearing PPE for a while, like in intensive care, you may be wearing it for an hour or two, then you may become hot or uncomfortable and you can't get a drink. So it's really important to look after yourself. Obviously tie hair back, get the jewellery out, check your PPEs the correct size before you put it on. The worst thing to do is get togged up and then find out you haven't got gloves the right size, so that's not good. So I'll go through putting on the PPE for aerosol generating procedures, but the principle is exactly the same and the order is pretty much the same. Well, it is exactly the same for just the surgical mask, apron and gloves. So hand hygiene first, then put on the long sleeve fluid repellent gown and fasten the necktie and the waist ties, and then the respirator goes on, okay? And it has to be one you're fit tested to use. And at the moment we've got 3 or 4 different types kicking around because suppliers will send us what they have. So they will substitute. We might think we're getting the 3M, but we get the Cardinal Health one. So they are better at substituting than Tesco's, because if you order a cauliflower at Tesco's, you get nappies instead because they haven't got the right thing. But you do get an FFP3 mask. Okay. What I would say is if you're mobile and like a crash team and you're likely to have to go to another area, take a mask with you that you know you're being fit tested for, because when you get there you might find they haven't got stock of that and they've got a different one, so that's useful. And if you've got to use goggles or safety specs, make sure they're compatible with the mask that you're using. So to check the respirator, you put it on, upper straps go over the crown of the head, over the ears, the lower strap goes around the nape of the neck, and then you make sure it's flat against your cheeks. And you use both hands and press this around your nose to get a good seal, because getting a good seal is absolutely crucial. You would have been fit tested. You then do a fit check, and that will vary depending on the type of mask, but most commonly it's things like doing a good suck in. And if you feel the mask come in, you know you've got a seal, because otherwise it would leak around. If you've got a good suck coming in, you know the air is going through the filter. If it's leaking around the outside, then it's not working and you do not proceed, because not all masks fit everybody. We all have different shaped faces. Yeah. Now, there have been some concern, understandable, when people get a mask out and it says expiry date is January 2020. The reason for this is that there is a huge stockpile for this sort of scenario, because you can't go to 3M who are knocking out 5,000 masks a day, because these aren't in millions of regular use, and then say, oh yeah, can you go from 5,000 a day to 2 million a day? They can't do that quickly, so you have the stockpile to get people over the time where the production is accelerating. And we have a stockpile, and it's been there a while, obviously, but the dates actually relate to what the manufacturers tested it to, and let me explain what that means. So on this mask here, for example, we've got a non-woven material of a couple of different layers here. We've got a plastic piece on the front, we've got a paper filter in there, which is the HEPA filter, and then we have stretchy straps here and a seal here. Now when you look at that, the non-woven's probably not going to deteriorate, the metal isn't, the paper won't, the plastic may, but only if it was exposed to UV light. So if you stored that in a box, it's probably okay. But this rubber here and this probably will, as you know, if you've had scrunchies and that sort of stuff, it all goes stretchy after a period of time. So what a manufacturer does is when they produce something like that, they think, okay, how long can you safely say that that will be okay without deteriorating it? And they put it in a special room with huge humidity and huge temperature, and sometimes with UV light, to see what the deterioration is like, and they leave it there for about 2 months. And that simulates 2 years, 5 years of exposure in poor storage conditions. And then they can say, okay, it survived 2 months at those extreme conditions, therefore under normal conditions it's going to be all right for at least 5 years, but they'll put a 5-year expiry date on it. Okay. So what we've got is, and so you'll see some of them, they might even have a little sticker over the expiry date with the new expiry date. Rumour went round that somebody just putting a sticker on to get us to use them. Right? We are not flogging dodgy meat from a supermarket that somebody stuck a new badge on and is flogging down the market. This is the NHS. So what's happened is they will have tested these masks. They'll have taken some from the batches, gone back to the manufacturer, tested and looked at it, and they said they're safe to use. And in fact, in some cases, the manufacturers have even stuck them in one of these machines for a week, and that's simulated a year's worth, so that's why you got a new date on it. Okay, not all manufacturers have been able to do that, but they will have been tested. Okay, but for any mask, have a look at it and say, is there any visible deterioration? And you will know when you've fit checked if it's working or not. And if it's not working, you don't use it. And if you find one that's dropping apart, please let us know. NHS did actually put out some guidance, which wasn't hugely well publicised, but it says some products may appear to be out of date, used by, have relabelled. Please assure products we're issuing have been passed stringent tests to demonstrate they're safe, it's exposed to extreme conditions for prolonged periods. Any that are not up to standard are destroyed and are not distributed to trusts. So Please don't worry about that. If it's arrived, it's okay. Putting the PPE on, eye protection then, you've got the gown and respirator on. Gloves, make sure you've got the right size, and then make sure you've got the end of the glove over the cuff. Then you're good to go. If you're not familiar, get a colleague to check you. More important is the doffing, okay? And that's where people have problems, and that's where things like Ebola cause problems, because people were coming out of areas, if they were working for an hour in horrendous conditions, in huge heat and humidity, wearing all the PPE, and they were not cognitively working very well at that time, and they made mistakes while they were taking the PPE off. Like they take their mask or the eye protection off and just rub their eye. And that's how they would get things like Ebola. So, we're not at that stage. It's not that sort of infection, but you do need to take your time. So obviously if you're working in an area and your mask gets damaged, you change it at that point anyway. But normally you would remove PPE in this order. Gloves off first, then the apron, then the masks and eye protection. I'll go through that in the stages. So the gloves, the outside of the glove is contaminated, so try and lift the edge and then peel it back. Don't put your hand inside to push it off, because your contaminated hand will then go inside and contaminate this hand. Okay, when you've got the gloves off, you clean your hands with alcohol gel. Then you are safe to remove the apron, because if you haven't cleaned your hands, then your contaminated, potentially hands, you're going to start contaminating around the back of your neck. So you've got your hands clean with gel. It's the front and the arms of the gowns that are going to be contaminated. You just undo it at the top and the back, and then take it down and let it roll down over your arms, fold it up from the inside, and then dispose of it, and then clean your hands again with the alcohol hand rub. Then the eye protection goes off. The outside will be the most contaminated. Then the respirator comes off. Okay, alcohol hand rub between the two, and at the end of it all, you wash your hands with soap and water. Okay, and that's good to go. Just get into the habit of doing this. It's the gloves, apron, eye protection, mask, lots of hand hygiene between them, and then alcohol, then soap and water at the end of it. Duration of mask wear, you wear a surgical mask till it becomes moist, or what you're doing is over. Do not drop it down for a while, wear it around your neck like a fashion accessory and put it back up again. You see plenty of people doing that, and then when they put it back up, they'll have to push it down around their nose again, and their hand's going near their eye, and they will have contaminated it. That's not good. FFP3 you get rid of after the aerosol-generating procedure, or if it's become contaminated, or after at the end of the care episode. Okay, but you can wear those for one care episode for a couple of hours, but it'll become quite uncomfortable after a while, and you get marks around you. But they'll be fine for a couple of hours, and you hopefully be relieved within that time anyway. Again, though, you don't drop those down and reapply. You will not get a good fit again. Okay, and you could get false assurance. Placing patients, the principle is we put the patients that we know are positive together, and we put the suspected together until we get the test results, which unfortunately are taking 2 to 3 days, which is not good. We try and put patients together who've been tested on the same day, so they're separate. If somebody's coughing a lot, you could put the privacy curtain between them and the next patient just to try and minimise droplet exposure, but there won't be a lot anyway because it's a couple of metres. Staff assigned to COVID designated areas should not care for other patients, and that's the people working a lot with patients, not somebody going in to, like a phlebotomist or something like that. There's no problem with people going and doing that with the PPE. It's just like flu from that point of view. Staff members working in COVID areas, if they'll be wearing the PPE for patients, so there's no point in them going. There's no problem with them going in their uniform or their scrubs to the restaurant, because they've been wearing the PPE while they've been dealing with the patients. Okay, they were just like any other member of staff who could be nursing a patient with infection on their wards. Okay, there's still flu around on the wards. Those nurses can go to the canteen, staff restaurant. So there's no problem with that because they've been wearing the PPE, and the people in the cohort areas are highly skilled at wearing the PPE. No issue with that at all. As usual, we need to change our gloves and aprons between patients anyway, because we don't want to transmit other bugs around, and we must decontaminate our hands between patients. If you have COVID, or you have symptoms like a fever and cough, don't come to work, let your manager know. Self-isolate for 7 days from the onset of symptoms. If they get worse, contact NHS 111, obviously. If you're at high risk of complications, then risk assess with your manager. Don't just not come in, but talk to your manager about it, and they may be able to deploy you to somewhere where you can help, because we need all the help we can get at the moment. And testing at the moment, we're just doing infection at the moment, which means people need symptoms, okay? And we're not doing contact testing, because if I'm positive and I move out and I test the person in the next bed and they're incubating, they'll test negative. So there's no point, it's a waste of a test. If you're a staff member and you just looked after someone, I want a test, it'll be negative. you might be incubating it, but we wouldn't get a positive on you. So that could give you false assurance, because if I'm 5 to 7 days, you've just got a bit of a cough, minimal symptoms like most people, you could think, oh, I'm fine, I haven't got a temperature, and you could be transmitting it. So that's important. But the antibody test will change, because that'll tell us how many people actually had the infection in the past. Just a bit about maternity, because we're on this site. I've been looking at the papers on this because people have been asking a lot about pregnancy and very concerned about it. There's a reasonable amount of fake news around about it as well, so I've been looking at the scientific literature and what's been published. So here's a paper that got published yesterday, on the 6th of March. The reports of 19 women to date affected by COVID-19. Okay, they delivered 20 babies, 16% of them, they had it, 16% were asymptomatic. One of them was admitted to ICU, no maternal deaths have been reported to date. There's no evidence of vertical transmission to date either, and actually when they go back to look at the previous episodes, like with SARS, there was a very low probability of vertical transmission from mother to fetus as well. So that's reassuring, but I'd like to see more evidence, but there's nothing to date. And there's been a lot of pregnant women in China and Italy who may have been affected. At the moment, we do not know whether this virus exists in breast milk. I haven't found any papers on that, so I wouldn't be able to give advice on that at all. But there does seem to be a possible increase in preterm delivery. So it may well be maternity needs to plan for the fact that people are going to be delivering a little bit earlier if they have COVID-19. And for actual care of the patients, we would do the same as we do in other areas like cohorting and PPE, etc., etc. Okay, thank you.